think good afternoon, my dear friends. So now myself and Dr. Usha are going to discuss on Adiposopathy, Sarcopenic obesity, lifestyle modification, challenges and strategies, and pharmacotherapy. It may look very long, but don't worry, we will finish it within 15-20 minutes maximum. Yeah, I think we all know what obesity is and what is adiposity we know. And I think now Usha will try to discuss what is adiposopathy. And we know obesity leads to various metabolic complications and adiposity also. Now, how exactly do they contribute? So that is what we are basically trying to discuss. And Usha.
So how we are going to do this session, we have half an hour. If the organizers ask us to cut it down, we will. But assuming that we have half an hour, what we're going to try and do, each question, we have about 10 questions. We're going to, between us, maybe spend a couple of minutes on it, and then we're going to throw it open to the audience. Now, in the interest of time, we're going to request, if you're going to ask a question, please think through the question, 30 seconds to ask the question. If you have comments, and we really want to make this not just a jugalbandi, but a whole orchestra. We want to make it a chorus. So 1 minute per person, please, so that as many people as possible get a chance to speak. So 30 seconds to ask a question, 1 minute for a comment. I'm going to also stick more or less to that kind of a span for each question. So what is adiposopathy? It's basically accumulation of fat as we understand it, but not just fat as such, but fat that has other effects. How does it contribute to metabolic dysfunction? We know that if you gain weight, there are mechanical problems, right? Joint pains, back pain, whatever. But beyond that, fat is metabolically active. Ectopic fat, if you have fat in the liver, if you have fat in the pancreas, if you have fat in the epicardial space, if you have fat in the muscles, we know this is what leads to diabetes, fatty liver disease, cardiac diastolic dysfunction, and insulin resistance. So depending on where you have ectopic fat. Fat is also an inflammatory organ. You know that outside of the designated endocrine organs, fat mass is one of the most endocrine, hormonally active depots. So when you think in terms of fat, interleukin 6, TNF alpha, all these are secreted from our adipose tissue, visceral and subcutaneous, and therefore adiposopathy is associated with inflammation. Now, I don't need to go on. We all recognize that inflammation is the root cause of many an evil, and that inflammation is directly related to our cardiovascular risk and other risk factors. So adiposopathy then leads to inflammation, which then leads to other cardiovascular risk factors. The third thing is that the fat depots are incredibly hormonally active. So you have, for example, leptin, you have other hormones that are secreted from your adipose tissue, visceral and peripheral. And then this makes this one of the most hormonally active tissues that we have in our body. Combining this inflammation, the hormonal dysregulation, the ectopic effects of fat, the metabolic dysfunction goes just beyond having fat. It matters where you have the fat and what it's secreting. So fat, where and what it's doing contributes hugely to our general health.
I think, as said, ectopic fat, we know pancreatic fat plays a very, very important role in diabetes pathogenesis. And even in direct study, I think they showed reducing the pancreatic fat, they basically cause remission of diabetes. I think even they suggested just 10 gram reduction in pancreatic fat can cause remission of diabetes. So I think this ectopic fat deposit, as rightly pointed out by Usha, is a major culprit for most of the metabolic complications by various other hormonal milieu and various other substances secreted by them. And we all, whenever we speak of obesity, any comment from floor? Yeah. No. Yeah, I think you'll be the first person.
We're going to come to the audience for every question. We're going to finish off our Q&A here itself.
Jugalbandi has got no questions, only questions. Anyway, it's a very important point that you have raised, is that the percentage of fat that happens in pancreas, which is coming down, that's what happens in bariatric surgery. Yes. The first thing that happens is that fat in the liver comes down, and so that the hepatic glucose output comes down. That's the first thing. And the next stage is that the fat comes down in the fat, that is glucotoxic, the beta cells comes, glucotoxic of the fat comes down, and then revival of beta cells will happen. I think that's a very good thing that your fat reduction in lipo and glucotoxicity.
And I think the other thing to mention, we're going to discuss medicines, drugs later, but the main difference between two of the drugs that we're using for weight loss now is that one of them actually redistributes your fat between the depots, and you see that there is a reduction in your triglyceride index and an improvement of your glycemia even before significant weight loss happens, and a reduction in your inflammatory markers and glycemia even before significant weight loss happens. So how you redistribute your fat also matters.
Yeah, I think when we try to discuss about various fat, I think the body composition matters a lot. So some people can have just an increase in fat mass. Some people can have increase in fat mass along with decrease in muscle mass also. So what we have been commonly discussing as the sarcopenic obesity. I am sure just the traditional obesity and sarcopenic obesity are two different spectrums, and the clinical outcomes could vary and the risk factors also could vary. Yeah. I think in this aspect, I am sure Dr. Usha would be trying to highlight how exactly these things are different.
So we know that when we talk about obesity, we have excess fat mass. But for us Indians, by nature we have less muscle mass. And when you add in age, the sarcopenia gets worse. Now, does that matter? Yes, it does. Because one of the most metabolically active tissues, if you will, for our glucose regulation is our muscle. And sarcopenia means two things. One, we are more insulin resistant, and two, we don't dispose of our glucose as effectively. Number two, functionally, how many of us, you can try this if you want, cross your arms across your chest, sit up from the chair with no support, both feet flat on the ground, stand up with no support. Now, a lot of you took support. You pushed up from the chair and then crossed your arms. The point is, you do this and stand up. Next step, how many of you can do it from lower down, from the floor, for example? No? This way. Okay, I'll have to take my shoes off to do that. Yep. Go on. Right. Up you come. Cross your arms, up you come. Right. Sarcopenia, here we come. Right? So this is the thing. If I can do it, and I'm 56, I think the audience should be able to do it. Right? So that is the next thing. Then frailty. As we age, this sarcopenia, we don't have core strength, we don't have girdle strength. We fall, we break things, right? So functionally we are impaired, we have worse metabolic indices, and as we age, we break things. And we know that the mortality with a hip fracture is huge. So sarcopenic obesity isn't just obesity. And remember, with obesity we rehab worse, because we have to carry that excess weight. You break a hip, how are you going to rehab if you weigh 20 kilos more than what you should be weighing? Where is your bone strength to carry that weight? So every single aspect of our well-being and health as we grow older is going to be impacted by sarcopenic obesity. Our lean muscle mass is what contributes to our insulin sensitivity, and we know that the insulin resistance is the, again, root cause of most evils in our health. So having adequate muscle mass and adequate muscle strength. So this is one. I can show you 2, 3 more if you want, but you should be able to do this with no support. If you can do that, you've got good muscle strength.
I think this sarcopenia again is a major limiting factor for us to do exercise, because obesity commonly we say lifestyle, diet and exercise. So whenever you have sarcopenic obesity, the exercise becomes a major challenge. So whatever kind of physical activity what we advise may not be able to be feasible for the patient. So such patient, the exercise should also focus on building the muscle mass along with the energy expenditure. Just a routine walking or energy expenditure may not be adequate. So any suggestions from the floor?
And remember, your diabetic patients with peripheral neuropathy, their joint strength and stability is incredibly important to keep them stable. Sarcopenia means that they have neither sensation nor muscle strength. So, to the floor.
Now, sarcopenia has been included as one of the complications of diabetes, like micro and macrovascular complication.
Exactly, yes.
And sarcopenia by itself can result in diabetes.
Yes.
Yeah. We're coming to that. We're down the line. We're going to talk about.
Sorry, I just wanted to make a comment about exercise. I think it's also important that we encourage our older people. Sir? They can also do upper body exercises. A lot of them don't want to do lower body. When you were mentioning strength training, so even with upper body, if they do some exercises and flexibility, all the hand or the things, all these things that we lose and diabetic patients lose earlier also. Once they start doing the upper body exercises, all of these things, they get more, and there are those exosomes that are made when you exercise, even your upper body, that still has an effect even on the lower body. So even encouraging people to just sit and do exercises. Yep. And that wonderful exercise you taught, Usha. So nothing, it's just to do sitting. I think that's what you should make all of us do.
Yeah, no, I do this. Okay. So
1 minute. Can I make a point, sir?
Sir, come around. This is open for discussion. So let's come here and then to you, sir. So let's go with you, sir.
Yeah. Sarcopenia assessment, you can use a hand grip meter. Then also you can.
So we're coming to that. We're going to come to exercise and how to assess in a minute.
Okay, please.
Yeah. Sir.
Sarcopenia is a geriatric condition where the muscle goes for weakness or slow atrophy or such things are all. Obesity complicates it. Okay. But we are talking so much about, even Dr. Vijayakumar was talking about so many statistics and all. Where we have to intervene, that is the point. If you see, the normal human body has about 30 to 35 million of fat cells. Normal, ordinary adult, fit adult. It can go up to 100, 150 billions. But if you see the growth, development of the fat cells, it is mostly decided by childhood or early adolescence. So that is why pediatricians, we recommend exclusive breastfeeding for 6 months. During the 4th and 6th months, you will feel that there will be a little starvation for the child. That is providing a good effect by long-term prevention against obesity, diabetes, and cardiovascular risks. So this has to be taken care of, number 1 point. Number 2, that is adolescence. So whatever
Sir,
the
all
interventions,
comments to 1 minute, please. Yes, but please try to keep it to 1 minute.
We want to provide, it should be even the early adolescence, including diet and exercise. Based on that foundation only, you can build on the obesity or sarcopenia management and everything.
Absolutely, absolutely.
The crux of the discussion is what is the difference between the sarcopenic obesity
Yes.
and traditional obesity. Now, to make a very simple definition, muscle loss plus obesity is sarcopenic obesity. No muscle loss obesity is traditional obesity. The underlying fact is that the sarcopenic obesity is prone for 2 complications much more, which is more serious in sarcopenic obesity. One is CVD and other is the metabolic disturbance. So sarcopenic obesity has, am I correct, Usha? It has more of CVD. I'm talking about sarcopenic obesity distincted from the traditional obesity by having more complications in the field of metabolism and cardiovascular disease. That differentiates.
Absolutely, sir. Sir, while you make your comment, the comment has just been made that sarcopenia is a disease of the geriatrics. Anybody under 40 here willing to come up here? Anybody under 40, if you're willing to take the challenge, come up. Sir, next your comment, please. So you wanted to say something, right? In the meantime, I'm asking anybody under 40. Yes.
Exercise, it is not the duration of the intensity, it is the consistency. உடற்பயிற்சி இடைவிடாமல் செய்யணும். அது திருவள்ளுவர் உலக பொதுமுறையில் சொல்லியிருக்காரு. மருந்துங்கிற அதிகாரத்தில் சொல்லியிருக்காரு. நோய் தடுப்பு பற்றி மருந்துங்கிற அதிகாரத்தில் திருவள்ளுவர். உடற்பயிற்சிக்கு திருவள்ளுவர் எந்த குரலுமே இல்லை. அந்த காலத்தில் மறந்துட்டார் அவர். அந்த காலத்தில் அது அவசியம் இல்லை. காலை கடங்க கழிக்கிறதுக்கு ஆற்றுக்கு போகிறாங்க, குளத்துக்கு போகிறாங்க, வாய்க்காலுக்கு போகிறாங்க. இப்போ அட்டாச்சு பார்த்துருவோம், வெளியே போக வேண்டியதில்லை. ஸோ லைஃப் ஸ்டைலே அது மாதிரி இருந்தது. அதனால் அது மருந்துக்கு உடற்பயிற்சிக்கு அதிகாரமே இல்லை திருக்குறளில். ஸோ நான் தமிழில் ஒரு சின்ன புக்கு போட்டிருக்கேன் டயபெட்டிஸ்க்காக. அதில் கொடுத்துருக்கிறது மருந்துங்கிற அதிகாரத்தில் மருந்தன வேண்டாம் யாக்கைக்கு அருந்தியது அற்றது போற்றி விடு. திருக்குறள் ஒன்றுமே இல்லை. திருக்குறளுக்கு என்ன தெரியுமா? மருந்தன வேண்டாம் யாக்கைக்கு தினமும் இடைவிடாத உடற்பயிற்சி பண்ணி கன்சிஸ்டன்சி. ஒரு நாள் கூட விடக்கூடாது. இப்போ இவ்வளோ நான் அட் ஏஜ் ஆஃப் 80 ஐ எம் டூயிங் ரெகுலர். நீ காலையிலே பண்ணிட்டு வர. ஸோ என்னால் முடியும்னா
we are running short of time. We have one more speaker. So I will request each one of you to take very little time and be specific, please.
Yeah, thank you, sir. Thank you, sir. Your point is taken. I think
it's an interesting topic. People want to contribute. Yes. It is not a geriatric disease. I challenge anyone under 40 to come here and do it.
Please use the mic so that.
If you are in sarcopenia, you have to correct.
From childhood. No, it is not a geriatric disease. The comment was made that it's a geriatric disease. It is not. I will tell you that no woman under 40 here and no man will be able to do a 1-minute plank. Nobody will be able to get up from the floor without support. There is a slightly more tougher version of this. Anybody under 30, under 40 come up here and will prove that it's not a geriatric disease.
We have to bring all the schools here.
Yeah. See, Dr. GVK did this talk about obesity in women. I tell you, obesity in women affects the next 3 generations. That's a different topic. I don't want to deviate from the topic.
No, regarding this protein that you are talking about, she is very right. The maximum muscle development happens by 30 years of age. Yeah. From then onwards, every decade, there will be 2 to 3% muscle mass will reduce. Once you are 50 and above, every decade, 20% of the muscle will come down. The only way that you do this, you have to replace the protein and do exercise regularly, like sir said. That's all. There's only 2 things.
Build your muscle during childhood and adolescence. Preserve it during adulthood.
I think
Dr. Vijayakumar says, sarcopenia is a natural phenomenon. As age advances, it happens. So you have to take precaution. As somebody rightly pointed out, elderly people have to do resistance exercise. There is no point in going for a walking alone.
Absolutely.
So I think having said about this thing, most of us define obesity by BMI or waist circumference. Yeah. But any people who are involved in clinical trial and I think basically they do various other factors to assess your fat mass and other thing. So
we'll finish whatever it is. We'll cut short the questions and finish on time. Interesting topic. We'll finish.
I think, Dr. Usha, do you feel any other alternatives or additions to assess your fat mass?
Absolutely. See, when we do a BMI, I always bring this example. You can look like a Danny DeVito, short, round, and have a BMI, or you can look like a bodybuilder and have the same BMI. So a BMI as such, of course, once you see the patient, you'll know. But a BMI as such on paper really doesn't give you as much information as it should. Adding in a waist circumference gives you one additional parameter, and that will differentiate between your maybe centrally obese and otherwise. But it still doesn't give you as much as you need. But for routine clinical practice, it's difficult to do much more. In our daily clinical practice, a BMI combined with a waist circumference gives you adequate information to be able to classify the patient. Beyond that though, if you're doing a DEXA scan, an MRI scan for fat mass distribution is probably a step too far. Or a simple, impedance meter. You have one of these body composition analyzers in clinic. Again, you can go low key, available for like 16, 15,000, or you can go slightly higher key, slightly more fancy, 25, 30,000, or research grade, which are much more expensive. That adds one more layer, and actually it's quite motivating for the patient, because I do BCA routinely in my clinic. And when you can show them how their fat is compartmentalized, what is their visceral fat, what is their subcutaneous fat, and more importantly, 3 months down the line, how they've managed to move that needle, not just 3 kilo weight loss, but actually your fat loss has been this much, that opens up their mind. So beyond just doing a BMI, always do a waist circumference in your clinical practice. It gives you at least one additional parameter. Beyond that, body composition, biomedical impedance, if you can add it, but everything else is only in research. We do use DEXA scans, MRI scans for compartmentalization of fat, but not in routine clinical practice.
I think the recent article...
Madam, I have one doubt, madam. In gyms, they do some non-invasive meter to compartmentalize fat. How reliable are they, madam?
Not research grade reliable, but blunt instrument to be able to give some information. But you know what, as doctors we have an additional thing. Whenever you do bloods, look at your triglycerides, look at your CRP, look at your HSCRP, look at other markers that gives you that one extra layer of information as to how much at risk these patients are. So adding to just the height weight BMI, you can also go one step further and look at your biochemical factors as well. Yeah, we're not doing metabolics and all the rest, but the minimum we can do is bloods.
It's about, what is the essence of this question, I feel, is to find out other indices beyond BMI, because today BMI is not the be all and end all of obesity measurement. Now we have decided to accept by an expert opinion, the waist circumference must be less than half of your height. This is given and is already published. Number 2, as you rightly said, sir, body impedance meter. But Usha, 50,000 rupees machine, we cannot publish any paper. We use the machine lowest, which is 8 lakhs, very steady. I will not advocating for the company, but that is very steady. So body impedance meter gives you entire body composition. The other measurements that have come up today are the skin fold thickness by skin calipers provided by the Government of India in the NIN, and also we do the assessment of the body fat in different areas, and that's how we today talk about obesity.
Thank you.
I think just before moving on to the treatment, one clarification from Usha is that I think there was an article published in Lancet in January. So they said just classifying obesity, apart from obesity being a risk factor, they defined obesity as a chronic disease. So it itself was a disease. I am sure. Usha, do you agree with it, or what do you feel?
I think it does two things for me. One, calling it a disease focuses our mind, because as doctors we don't do lifestyle that well. None of us really spend much time advocating. We talk about it in meetings, but in routine clinical practice, none of us spend even 10 minutes per patient talking about lifestyle. So calling it a disease focuses our mind. My one point of disagreement, if you will, with that article is by classifying it as subclinical and clinical, or preclinical and clinical. I don't feel that the preclinical is any less important, because if you leave it, oh, it's only preclinical, that's a lost opportunity, because preclinical is actually where we should be intervening to prevent it becoming clinical, because preclinical is before they have any manifestations of obesity. Clinical is once they have something, sugar, BP, whatever. I think we need to intervene at the preclinical stage. But on the whole, it actually gives us, this is a disease, we need to do something about it, we need to measure it, we need to treat it.
Exactly. When you
Exactly.
Exactly. Once when you decide to treat, what are the most effective lifestyle interventions specifically to improve sarcopenic obesity? I'm sure Dr. Sulaiman sir and various people were discussing these things.
Actually, I'm going to hand it over to the audience, because 2-3 people already mentioned sarcopenia. And
I just want to say, when you say how to classify obesity beyond underweight, normal weight and overweight, one should today classify the clusters of obesity. I thought you will give little bit of metabolically healthy obesity. We have got 4 clusters, like diabetic clusters, which Mohan might have told yesterday. We have 4 clusters of obesity, MOH. There is metabolically healthy obesity, metabolically non-healthy obesity, lean healthy obesity, lean non-healthy obesity. And those 4 clusters have been well defined today.
You are going to forgive me. I'm going to beg your forgiveness already. I don't believe in metabolically healthy obesity. Yes? Please forgive me ahead of time, because I think you are metabolically not yet unhealthy obesity. I don't believe in metabolically healthy obesity.
Whereas we also differ. I believe, after this talk by Dr. Vijayakumar, that today we accept obesity as a disease. If you do not accept it, if you say chubby boy, chubby gentleman, I think we are doing a mistake. That is for 3 things: inflammation, cardiovascular disease. There are 299 diseases associated with obesity. 299 diseases associated with obesity. So there is another point of disagreement, Usha, with you.
I think this metabolically active obesity could be a preclinical stage of obesity. So we should catch, that's what Usha has been insisting, we should catch them at that stage so that they don't advance to metabolically
not yet unhealthy. For now healthy. Yeah. So,
only one doubt, ma'am. The thing is that, sir, now yesterday only one WHO seminar they have told, and they told that obesity term should not be used. We should say that, adiposity based chronic disease we should say.
Yeah.
And
that's already
there. ABCD is,
But it is that's just to remove the stigma. But ABCD, whatever name you give, I mean the Dr. Aditya is the same. From Hyderabad, no?
Obesity is something that tells people, everybody understands it.
Yeah.
If I start talking today about ABCD, half my audience will be like,
we'll understand the music.
Yes.
Usha,
You have seen that film, no?
a question to you. You said you don't agree with the metabolically healthy obesity, but there's a theory, set point theory, where the body prevents weight loss beyond a set point, trigger mechanisms come in the body, which is natural. then it should be healthy for that body.
So there is Roy Taylor data, if you see which study was it, where somebody went from a BMI of 18 to 23 and became diabetic. So for each individual, I agree that there is a set point at which you're healthy, and for everyone has a personal fat threshold. This is what Roy Taylor says. And if you exceed that personal fat threshold, even at a BMI of 25, you can be obese and unhealthy for your personal fat threshold. There is one more question if we have time, but what you're talking about is when we are losing weight, everybody reaches a threshold beyond which you can't break through. And that is because of metabolic adaptation. And there are ways of getting through that. There are ways of breaking that, if you will.
Then in the case, there are certain risks in obesity where they do not respond to treatment at all. They maintain the same weight. Would the same triggering factors be operating in them to prevent the weight loss, even the initial weight, not the rebound weight gain, even the initial weight loss, so that that weight is healthy for that particular individual?
Yeah. So when we say that nobody loses weight, most often it's because I think we are not doing it the right way. We just tell patients eat less, move more, and on the other hand, there is something as eating too little to lose weight as well, with inadequate calorie intake. So sometimes when you're talking about obesity management, it's so nuanced that when somebody comes and says, I've tried 100 different things, I've not lost weight, it takes me 45 minutes to 1 hour to get a proper history to then give them a plan for weight loss. So personally, I think there are always people who won't lose weight, but for 90+% of them, if you dig through, you'll find where it's going wrong and you can change that trajectory.
You should have a controlled trials on such patients, see what is happening, like RCTs.
Yeah.
Yeah, I think Usha
So
will
effective
just
interventions: increase protein intake, increase your resistance training, try and increase your NEAT metabolism. So when you're not exercising, if you keep build muscle, you'll keep burning. And sometimes supplementation, because we get dietarily impaired, shall we say, deficient when we do this, you might need supplementation, including with magnesium and other agents. And
even this protein intake should be evenly distributed. So you see to that you take it regularly.
And sleep enough.
And I think yes, sure.
Can I give a point?
I think in spite of so many things.
Discussing so many things are all the evidence-based medicine, which has come into our medicine since 1990s. There are two things. One is an evidence-based medicine, and it's a time-tested medicine.
Yeah,
I think Dr. Das is talking about weight loss.
We have a talk.
Then we'll pass on.
If you go with the time-tested medicines, you can take many things from Ayurveda also. I have done a lot of I don't say research.
Sir, I think we are running short of.
I will give it in a nutshell.
Yeah.
Okay. So what the Ayurveda really prescribes is to take your first food in the morning by 12 o'clock. That's the time it coincides with the increased release of the insulin. And it says finish your dinner by 6 o'clock. After that there is no food. This is almost coincides with our now evidence-based intermittent fasting. Number 2, they ask us to go to early to bed and rise early in the Brahma Muhurta by 3:30 in the morning. So, and these are all the habits that will naturally give you a healthy life. And of course,
Can
now
you make
it is
it
modified.
we are running short of time, sir.
Yeah. But this is a valuable point, sir, for which we have been slogging for 2 days. Eat a light breakfast at 9 a.m., before 9 a.m., not like because of with our lifestyle.
Sir, yes. I'm going to have to ask everybody to stay to 1 minute at the most, please, because we have other topics and now we're going to have to close it. Thank you so much. 1 minute for anybody and everybody, but please keep it to 1 minute because we want to move this along. I don't want to offend anybody. Apologies.
Yeah, last question.
Yeah. So what are licensed? We have Orlistat, we have GLP-1 and we have GIP-GLP combinations. These are the only licensed drugs for obesity. The strength goes up from Orlistat to GLP to GLP-GIP combinations. Start early. Use them for whatever goal you have and you may need to reuse them for the future. I'm only talking about the weight loss benefits, not about the other cardiorenal metabolic benefits. If you're using it plainly for weight loss, start early, use it to reach the target. You may need to top up once they start regaining.
I think since we are running, we'll stop with this. Yeah. Thank you, audience. Thank you, chairperson, for your patient hearing. Thank you.